Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Sleep medicine practices rely largely on E&M coding from clinic visits to generate revenue. There is a lot of uncompensated work, such as reviewing downloads, making pressure adjustments, or reviewing patient questionnaires. Remote patient monitoring codes have been active for a number of years. They have largely been used to monitor blood glucose levels via a continuous glucose monitor or to adjust heart failure medications via a connected digital scale. Should we also be using RPM or RTM codes in sleep clinic? How complicated is this? Which sleep disorders qualify for this billing? How onerous is the documentation? Do we need to invest in a specific platform to facilitate this billing? Here to help us navigate remote patient monitoring are Dr. Charles Bae and Dr. Gabriela de Bruin, the chair and vice chair of the AASM Coding and Compliance Committee. Dr. Bae is a neurologist and an associate professor of medicine at Penn. Dr. de Bruin is also a neurologist and works at Washington University. They are here to explain these codes and to help us decide if we should adopt them into our practices. Thanks for joining us today.
Glad to be here.
Good to be here. Thanks for having me.
Okay, so let's level set. Chuck, what is RPM?
So RPM stands for Remote Physiologic Monitoring. It's a set of codes that CMS published in the 2021 final rule that allows practitioners to act on remotely collected physiologic data as long as work is being done from patients, and they can be done for acute and chronic conditions.
So is it like an E&M code?
It's a set of CPT codes for which, there's a detailed definition as to, what reimbursement can be collected for a certain amount of work that's done. And in this case, you're acting on physiologic data that's being automatically collected from FDA-approved devices.
So you need to monitor a physiological variable?
Yeah.
Correct, for the RPM codes, and then we'll contrast that to RTM codes, remote therapeutic monitoring codes.
Okay, so Gabby, tell me about those. What are RTM codes?
So RTM codes are newer codes. They're remote therapeutic monitoring services. So in contrast to remote physiologic monitoring codes, where you need a device to automatically monitor and transmit physiologic data, remote therapeutic monitoring codes can be used for data that's submitted by the patient and data that's patient reported. So the device doesn't necessarily need to be automatically capturing that data.
Oh, interesting. So is that kind of like a CPAP might be RPM, but like a sleep log would be RTM?
Exactly. But it's important to note that the remote therapeutic monitoring codes, the RTM codes, are only defined for certain subsets of conditions like musculoskeletal conditions, and then most applicable to sleep medicine, respiratory conditions, and behavioral therapy.
Oh, interesting. So when we're talking about devices, does it have to be prescribed like a PAP device, or do wearables count?
The device does not have to be prescribed, but it does need to be medically necessary and reasonable for evaluation and management of that condition. So it needs to allow you to get meaningful data from the patient, data that truly allows you to measure the variable that you're interested in, and then make reasonable recommendations for patient management based on that data.
Just one more point on that is that in addition to the medical necessity, you need to make sure that the device that you're using to automatically capture the physiologic data meets the FDA definition for a medical device. And if you have a question about that, there's actually a website that you can look up if you search how to determine if your product is a medical device. And there it gives the FDA criteria for what is considered to be a medical device.
Oh, interesting. Okay. And then we'll have a link to that website then. So walk me through this like I am 5. So if I want to do this, what are the specific requirements?
So you need to have an established patient. This can no longer be done for new patients. So it has to be an established patient in your practice that you're managing a condition. For remote physiologic monitoring, that patient needs to have a medical device that is, depending on the code, if you're billing the practice expense codes where you're billing for their use of this device has to be automatically downloading data from the patient, and you need to collect 16 days of data for every 30 days of monitoring. In addition to that, the patient has to consent to this. When you bill this code, any copays or deductibles that are linked to the patient's insurance will apply. And in order for the patient to be aware that those charges are going to be there, they need to consent for this treatment.
Okay, so they opt in.
Exactly.
Oh, okay. And so are there specific sleep-related devices that would fall under RPM billing?
So currently, there's nothing that is like specified by the FDA in terms of FDA-approved devices. However, in terms of what we do as sleep specialists, certainly we collect a lot of physiologic data from CPAP machines. I think time will tell, as more people are using these codes to help people become compliant with CPAP. But the classic kind of examples for RPM include weight, blood pressure monitoring, and continuous glucose monitoring.
I think that's why I've kind of struggled with this, because I get that, right? I get the continuous glucose monitoring. I get the daily weights. I get the blood pressure. I've always kind of struggled with how does this fit into a sleep practice?
And I think that's why a lot of people haven't done this yet, just because out of concerns like, well, can I really use the practice expense codes, without the the codes that are used for the amount of work that we're doing. But if you kind of look at the details of the different, types of codes, if you just ignore the setup codes and the data collection codes, it actually might be a lot easier for a practice to start incorporating remote patient monitoring into their kind of daily care of patients. Because think of all the data that's being collected and being acted upon. Now, you're already doing this potentially, and you can't get credit for printing a download and looking at it, but you are looking at the data. And if it results in a 30-day period where you're doing 20 minutes worth of work, and in that 20 minutes, there is a requirement for interactive two-way communication with the patient, either with, say, a phone call or a video visit, but that's not the entire 20 minutes. So there may be, 15 minutes worth of reviewing the data that's being collected. You decide that it makes sense to reach out to the patient. And again, it could be someone that works with you as well to say, hey, you need to interact with this patient. And so you talk to the patient, come up with a therapeutic change or a plan, say, maybe change the mask or come in and let's adjust your settings. And then as long as there's 20 minutes worth of work that's documented somewhere in the patient chart, then you can legitimately start billing for RPM codes.
So what if it's like, does the communication have to be between me and the patient, or can it be like somebody in my clinic?
That's a really important point. It depends on the code. So for 99091, which is one of the codes for billing for the work of interpreting and communicating with the patient, like Chuck just pointed out, that code has to be performed by a physician or a qualified healthcare professional, meaning which CMS defines meaning as another healthcare professional that is able to bill E&M codes under their own scope of practice. So a nurse practitioner, a PA, for example. For the 99457 and 99458, which are other codes that you can use for interpreting the data, those can be done by clinical staff. So you could have a nurse in your practice, for example, doing the monitoring, communicating with the patient, and then they would add their total time spent on that and bill incident to the physician in that practice.
Oh, that to me makes it a lot more doable. When you look at a stack of downloads and then you write down or message about what's happening here. And, when you see an elevated AHI, for example, and then you call and the patient had surgery, or something. But that back and forth then, that usually happens. It sounds like this may be a mechanism to capture revenue for work you're already doing.
Absolutely. And as long as you meet that time threshold in a 30-day period, that threshold is different for the 99457, which is the one that can be billed by clinical staff. That's a 20-minute threshold Whereas for 99091, which is the physician or advanced practice provider only code, that threshold is 30 minutes.
How hard is it to document?
I think that depends on how your practice is set up. Many people have some sort of electronic health record in which these type of interactions are documented. So it's a matter of timekeeping. I mean, currently there's no great way to, for the systems to kind of automatically track how much time is being spent by, the person doing the collection or the, kind of interacting with the provider. But it's similar to what we do in clinical notes. If you bill by time, we're attesting that we're spending X amount of time before the visit with the patient and also after the visit in terms of activities related to patient care on that scheduled day of service. So I think it's the same vein, where it's just setting up a system where, someone spends however many minutes to download the data, then say the provider looks at the data, then waits, to see if any changes need to be made, but then also making sure to take into account the time spent, if that results in a phone call to the patient, or if you say, hey, let's just, do a quick video visit, which may not be billable per se, but it's just for purposes of remote patient monitoring. I think, so it all depends on how you set up your system for just time tracking.
So maybe like a quick addendum or something. I spent 7 minutes reviewing the download.
Right, and then that can be all added up. Now, to something that I just said, if what you do is say, hey, schedule that patient for a follow visit, then you can't bill RPM in the same 30-day period. So what this is meant for use in between visits.
That makes sense.
You can't have double dipping.
Yeah, well, and that's fair, right? I mean, we want to do what's right by our patient, and we want to follow all the rules. I'm just kind of thinking about how much time we spend day to day that isn't compensated, and then I think a lot of organizations, you have to sort of demonstrate that you are, doing this much work. And if this work isn't tagged to some sort of revenue, it kind of doesn't count.
Absolutely.
Yeah.
And I think that leads to burnout.
And it can be difficult for people to maintain their practices as well if they're doing
absolutely.
a lot of work that is not being recognized.
So do you need special software then to bill for this?
You do need to have a mechanism to review the data that's being automatically downloaded from the device. There's no stipulation that there's a specific type or specific kind of software that you're going to use. For example, your routine online platform that you use to look at uploaded patient PAP data would be adequate for looking at data that's being collected. So you don't need anything that's unique that you're going to have to go out and buy specifically to do this. Some of the software that we're already using in our practices would meet the criteria. But as was mentioned in the beginning, this does need for remote physiologic monitoring to be data that's automatically being collected and uploaded. So it can't be something that the patient's writing down on a piece of paper and then bringing to your office.
And one point, I think that, in the vein of making sure people are following the regulations and the guidelines, is that I think to bill for the practice expense code, so the 99453 and the 99454 codes, those are the codes where you do need to collect a minimum of 16 days of data in a 30-day period. And so in order to bill for those codes, there are platforms that exist now that are approved as an SAMD, so software as a medical device. So if a practice decides to work with one of those companies that has one of those platforms, then you're able to bill for those two practice expense codes. But if you decide not to go that route, but you're definitely looking at the data after being collected, and then a decision is made as to how to improve a person's compliance, or depending on what the issue is, then the focus certainly would be on the 99457 and the 99458 codes, and then that wouldn't require investing in any other platforms for data collection.
Okay, so walk me through all of these codes.
So the main ones in consideration, would be 99453, that's a one-time code for kind of the setup and the education on the equipment that's provided to the patient.
So like CPAP setup.
Right.
If you did CPAP setup in your clinic.
So I'm not sure if that would apply though.
One of the things that's important is that these codes should not be used if there's another code that covers that service that's more specific for it. So if you are providing durable medical equipment in your clinic and you already have a setup through which you bill for that equipment, you can't then tag on this code for that existing billing structure. So that's really important. And if the device is not yours, if the CPAP is being set up by a durable medical equipment company, you can't then use the setup code for that CPAP that's being provided by a different company.
Yeah, that totally makes sense. That makes
And that's
sense.
the difference between, say, like CPAP and blood pressure, because a practice is probably purchasing the blood pressure cuffs that are being given to the patients, and then you start the data collection. So that's where you can use the 99454, the 99453, 473 codes to then for the data collection piece. Then you have the code used for the provider work, which is the 99457. I think that's the one that most people will use because that's for the initial 20 minutes of work being done in a 30-day period. And it's not all consisting of a two-way interaction with the patient. And so if you do more than 20 minutes, say 40 minutes, then you can add a 99458 code. So if you do 39 minutes worth of work with, say, like a 2-minute phone call, you can only bill a 99457 for a 30-day period. Now, if you truly do 40 minutes of work, then you can do both a 99457 and a 99458 code.
Oh, wow. I bet that doesn't come up very often because I bet those are the patients you see back anyway.
Exactly. I mean, at that point, you might as well have a visit with them.
Yeah. Okay, so this is a big ask, but can you go through the codes and help me understand? Because there's a lot of codes, right? There's like 7 codes in this family. Like, help me understand which ones I can use.
So in the remote physiologic monitoring family, which is the family where that data is automatically collected and transmitted by a device, there are 7 codes. 2 of those codes are for blood pressure monitoring, so we don't need to worry about those.
Okay.
Of the remainder 5 codes, 2 of the 5 are practice expense codes. So those are codes that are used for billing for setup and education of a patient with a device, and then for the patient to have the device in their home collecting the data, as long as it's collecting at least 16 days of data in a 30-day period. So those practice expense codes are really for when you own the device and you are doing that setup and the patient is taking your device home and using it to capture the data. The other 3 codes are the ones that have to do with physician work. And those codes are based on the amount of time that you did work in a 30-day period. 99091 is work that's done by a physician or a qualified healthcare professional. And then 99457 and 99458 are also work interpreting data and communicating with a patient, but those can be done by clinical staff.
Oh, okay. So there are 2 that can be done by clinical staff and 1 that has to be done by the physician.
That's correct. And those codes are based on the time that you spent reviewing the data, making a plan, and communicating with the patient. They don't necessarily require that you look at 16 or more days of data. So if you've spent, as a physician, 30 minutes reviewing 10 days of PAP data in a really complicated patient, and then did a long phone call with that patient to come up with an adjustment plan, and then you put that into the chart, and that was more than 30 minutes in a 30-day period, you can do 99091 even though you reviewed 10 days worth of data.
Oh, that's helpful because that does come up every so often, doesn't it?
It does. Many of us have already done that or do that on a regular basis for our patients.
So, and along those lines, if it's only 20 minutes worth of work in a 30-day period, then the 99457 code would be applicable.
So that's the important one. I've heard you say that one before. Okay, that's an important one to stick in my brain. So it sounds like we've kind of talked about how to apply these codes in the context of OSA management and PAP therapy. What about like actigraphy and wearables for insomnia or hypersomnia? Is there a role for RPM or RTM coding for those disorders?
So for RPM codes, it all comes back to whether or not the device collecting the information is considered to be a medical device by the FDA. So I would encourage everyone to go and look at the website, government website, to see if the device that you're using meets that criteria. But then also RPM requires that any data that's being collected is automatically transmitted back to the practice of the provider. So it cannot be reported by the patient after, say, a week of data collection. The patient can't then send the report back to the practice.
Oh.
And then that's where maybe you can start thinking about remote therapeutic monitoring codes in that vein, because that does allow patient-reported data or transmitted data from the patient back to the provider.
Well, and I feel like that's becoming a larger part of our practice, right? When you're, looking at wearable data, or you're looking at what their bed says, or something like that. I suppose would that be considered patient-generated health data?
Well, right, because for remote therapeutic monitoring, if we're going to shift into that, it doesn't require necessarily kind of physiologic data, but certainly patient-reported outcomes can be part of it. So certainly questionnaires, we do ask our patients a lot of different questionnaires, either validated or just homegrown. And so depending on how patients respond to different therapies, for example, even daytime sleepiness, for now, the Epworth Sleepiness Scale is kind of the one that's used the most, even though we all know that it has its own, limitations, but that's the one that's used the most in practice. But if you were to ask the patient that questionnaire, or they're to kind of do a self-rating on a daily basis, certainly that's one way you can kind of determine a response to a medication for sleepiness, or for that matter, there's other scales such as the Insomnia Severity Index or other scales for insomnia that certainly you can ask the patient to complete, while they're going through CBTI. So there's different ways to, be creative, I think, in terms of understanding RTM requirements and seeing how that can apply to sleep.
Well, and I love how you're thinking about it outside of just OSA, because we do spend a lot of time reviewing sleep logs, for example, or like you're saying, trying to assess how is this medication working for you. And sometimes it's hard, right? Because it all sort of blends together, but then having something objective that they've documented maybe every morning on their app or their sleep log or what have you, and then they're reporting that to you. So that might be a reasonable way to use this.
That's right. And I think it, also to refer back to one thing that Gabby mentioned early in this discussion, is that currently CMS has kind of detailed, there's 4 actual clinical uses for RTM codes. So anything that relates to the respiratory system, so still sleep apnea, you could kind of put into that category, musculoskeletal system, medication adherence. So we do prescribe a lot of medications for sleep disorders, and also therapy response, kind of go hand in hand. So if you look at it in terms of the latter two, that's where I think RTM could be helpful.
So let's take a short break, and when we come back, we'll talk more about RPM and RTM coding. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Are you a medical fellow or resident looking for the right specialty for your career? Sleep medicine is quickly gaining recognition as a fundamental discipline of health and wellness. This specialty offers medical fellows a unique opportunity to delve in an ever-evolving field. Interested in expanding your knowledge base through industry-leading research and professional growth opportunities? Join over 9,000 AASM members dedicated to helping patients achieve optimal health through better sleep. Learn more about membership benefits at aasm.org.
Welcome back to Talking Sleep. We're talking with Dr. Bae and Dr. de Bruin about how to use RPM and RTM codes in a clinical sleep practice. So, do you think this is something that is feasible to implement in a small system? And I'm, of course, thinking about my own tiny practice. Or do you need, certain infrastructure in place? Is this sort of meant for larger organizations?
You absolutely could do this in a small system. I think some of this is work that we might already do in our practices that can be captured by these codes. And we've talked a lot about CPAP monitoring, and that's, it becomes, there's probably more ways that these codes can be used, and we're going to learn more and more about ways where CMS is going to be comfortable with using these remote monitoring codes, and I'm sure new codes will come up with time. The app is something that we do right now. It's a device that automatically captures and transmits data, and many of us already have complicated patients where we go online and may have to do a couple of rounds of reviewing their data and doing adjustments. And in a complicated patient, that could easily hit 20 minutes in a 30-day period, or maybe even 30 minutes in a 30-day period, allowing us to bill for these codes.
Well, and I think it's so important for us to think through the workflow that we already are utilizing, right? It's not like we're trying to find something to fit into this code so we can build a code. It's the other way, is that we're already doing this work. Is there a way to get recognition for the work that we are already doing?
That's right.
Absolutely. And I think that also gets back to the whole issue about consent. Since this is a, reimbursable CPT code, I think it would not be good if practices didn't do this just because they couldn't bill for it if the patient decided to, opt out. But certainly, I think, as you mentioned from the start, is that this is just one way to get reimbursed for something that most of us are already doing in terms of what we do for our patients with sleep apnea who are, not only set up for the first time with the CPAP machine, but even they're good users where something may come up where they become either less compliant or non-compliant. So then, one way to think about this is when's the best time to do RPM? Certainly for the first 30 to 90 days until a patient's compliant, that's certainly a good way to establish medical necessity. And then also too, once they're compliant, you wouldn't continue to bill for this until an issue arises where you notice that a patient's not using the machine, or it's less than 4 hours a night, or there's a high leak. Then it makes sense to ask the patient, hey, I'd like to monitor your data, which you probably do anyway, but then get their consent for this RPM, and then kind of repeat it until they're back to being compliant.
So do you have to re-consent them?
The best practice for these codes, and consent requirements can vary locally based on the MAC. So we always tell folks to look at their local requirements for consent and documentation. So that's really important. But we recommend that the consent be obtained for every episode of care. Is that right, Chuck?
Okay.
I think that's the most conservative way. Just like you said, I think, sometimes there's annual consents that are obtained for patients who come in for visits across all specialties. So that's one way to look at it. But I think just to avoid any misconceptions or things that may happen in terms of billing, because the worst thing that happens these days is if a patient gets a surprise bill. And so, just to be upfront and just letting a patient know that you're going to be using the physiologic data that's being collected to help them become compliant with CPAP, I think makes sense. And I think most patients would appreciate that, but you got to have that conversation.
I would actually welcome that conversation. I remember years ago when I was wearing my pulmonary hat, they started reimbursing for tobacco cessation. And I forget what it was. I was in a large organization. And if you documented that you asked them to quit smoking and you kind of talked about it for 3 minutes or 5 minutes or whatever, the coders would then bill for it. And then patients got really upset because a lot of the time it fell to their deductible, or it was not recognized by the payer or something like that. And so I think I would much rather have that conversation up front rather than sort of finding out about it afterwards. And, because at that point, patients are like, I already know I have to quit smoking. You're not telling me anything I don't know.
And maybe it just caused them to smoke more. Who knows?
Well, and that was just sort of my experience a long, long time ago. So maybe I have a little bit of apprehension. So I like this idea of doing it by the book and, doing it for the stuff we're already doing, and then maybe getting a little bit of reimbursement, right? And it does help us, help our patients. So I kind of like that. And I like the idea of transparency and consent. So do you think at some point, we're talking about physiological data flowing in, Is AI going to do this for us?
AI can do everything, right? But
Evidently.
the thing that people don't think about is what does that mean? Because the CPT codes really are designed to kind of help healthcare providers get reimbursed for the work that they're doing. And so, sure, AI can collect the data and do the analysis, but if that results in less than 20 minutes worth of work, for a provider in a 30-day period, then you can't bill these codes. So I think you have to be careful what you not wish for, but what your desired outcome is. If you have a huge practice where it makes sense for an automated platform to take in the information, process it, and then determine who needs, a phone call or kind of a quick video interaction that's not a visit, then that makes sense. But for small practices, I think not to say that we need busy work, but if AI were to come into play, and if it's required, then I think this would certainly be used less. But I think it just depends on each person's provider situation.
So if we start to use this code more, it will ultimately be scrutinized by OIG at some point, right?
Right. I think the utilization of all the codes is always being looked at. So if there's a big spike in numbers, remember what happened to our field when, all of a sudden the codes for, CPAP and, sleep studies went through the roof. And, here we are now. And so certainly not just sleep, but, other specialties are definitely looking at this code set. The obvious ones are, cardiology, endocrine. And so they're going to be used more. And just to kind of, case in point is that in November of last year, right before Thanksgiving, the OIG did issue a consumer fraud report related to, remote patient monitoring.
No way.
And it was mainly because of, I think, some cases that were brought to their attention in terms of course, bad actors, in the sense that patients were being contacted about potential RPM and different things were happening. One is that, maybe they never got the blood pressure monitoring cuff that they were, promised, or the blood pressure monitoring cuff for whatever device was not an FDA approved, not FDA device. So again, it doesn't have to be a registered or cleared device, but just something that's considered to be a medical device according to the FDA. And then also too, the biggest one was that it was hard to prove that the RPM was going to be medically necessary. It's like, how is it going to help the patient? So that's where it gets back to the regulations. And so I think even if these codes get used a lot, as long as everything holds up, say if you get an audited, then it should be fine.
Yeah, because we're doing things that are necessary, right? Like monitoring CPAP downloads and all of that stuff.
Right, to help patients get compliant with CPAP.
And to your point, Seema, these are new codes, and so they are going to be monitored a little more closely. And it's not to say people shouldn't be using them. We certainly don't want people to be scared away from using codes that are appropriate for the work that they're doing. But when a code is coming out and we're learning about that code, it's probably not the best time to push the envelope and use it in a very unorthodox way. So look at the rules, document everything appropriately, and use it for the intent in which it was created. And as we learn more about them, then we'll also get more guidance as what are maybe less usual circumstances in which they used appropriately.
Yeah, I think that's very reasonable. You start, you get used to it, you see how it works, and, follow the rules.
That's right.
So your group created an RPM implementation guide, right?
Yes.
That's right.
Okay, so tell me about this.
So it's a living document. It's on the ASM website.
It's in the telemedicine section.
That's right.
Oh, perfect.
And it's a remote therapeutic monitoring guide. Actually, it's a remote monitoring services guide. It includes both the remote physiologic and the remote therapeutic monitoring codes. And it's a living document. As we learn more about these codes and adjustments are made, then we can keep the guide up to date. And it's really broken down really nicely, where It has the backgrounds, the intent of the codes. It breaks down all of the codes, and it walks you through how are these codes meant to be used? What is the practice set up to make sure you're billing these codes correctly? So really has everything we covered here today.
I'm really sorry I missed your webinar that was held in April, but I'm going to catch it because it's on the ASM website now.
Yeah, if you have burning questions about RPM and RTM, that is a great resource. We answered a lot of different scenarios and different questions, and there were some that we couldn't answer. We got some tough questions too, and the email for the Coding and Compliance Committee is always available for folks who maybe have questions that we didn't cover today or at the webinar.
And that's coding@aasm.org?
That's
Yes.
right.
Okay. So I have kind of a silly question to ask you. What is it that the Coding and Compliance Committee does? Is it all about like looking into new codes and helping us understand them?
Well, so the main purview of the committee is to certainly look at existing CPT codes, how they're used, also, DME codes, and then also to look at how the codes are valued according to the RUC committee. So that's something that there's two parts to this. There's this CPT side and the RUC side. And so our committee focuses more on the RUC side of things, so the relative value scale updates put forth by the AMA. And then once we kind of look at the issues that come in or things that come up at a national level, then our group discusses them and then submits recommendations to the ASM Board of Directors.
So, and we almost lost, that's where we got into trouble a few years ago, right? Where we didn't have a member that was part of the RUC.
Right. So each specialty society needs to have a certain amount of AMA members. And I know that for most, it's unclear to them what the AMA does for them, which is why they decide not to become members. But unbeknownst to them, the AMA actually does a lot for all physicians, members or not. But in terms of having a seat at the table, that does require a certain percentage of a specialty to have members for the AMA. So again, as you mentioned a few years ago, that there were not enough members, ASM members who were AMA members. So then we were not part of the RUC process until we corrected that.
Well, I mean, I will admit I was in the camp of, why am I an AMA member? So then I was like, this is expensive. Why am I doing this? And then when somebody mentioned, because then we get to have representation at the RUC, I was like, oh, okay, I get it. So, whether or not I was sort of in agreement with, what AMA was doing at that time or not, I was like, oh, okay, now I get it. But yeah, I was totally in that camp of like, why am I doing this? It's so expensive. I don't want to do this anymore.
Right.
That's true.
Exactly.
A lot of people don't realize.
Yeah, no, I didn't. I totally get that. So any final thoughts?
I would say these codes are here to stay. They cover a lot of work that we are already doing. Some of them, the threshold to use them is not that high, is work that many of us do repeatedly in a regular month, and we should use them to get recognized for the work that we do. But they are early, and it's probably good practice to make sure we're following the rules. It's always good practice to make sure we're following the rules, but really to make sure we're being maybe a little bit more conservative, since these are new codes and probably going to be reviewed as time goes on and they get used more.
And also, not to sound like a broken record, but if you are going to do this, I think make sure that you get the consent from the patient, and then also document two things. Is it medically necessary for you to, manage that chronic condition, sleep apnea? And then also, two, the time spent in a 30-day period, 20 minutes for the 99457. And if you meet that threshold, then yeah, I think you can legitimately incorporate these codes into your practice.
Well, thank you both for joining us today and helping us to better understand RPM and RTM codes, and for giving us concrete ways that these can be utilized in a clinical sleep practice.
Thanks for having us.
Thank you.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.